So welcome back, everybody. It's time for another edition of Living Hope, the one show designed to, talk to the people who are really going through this on a regular basis and help provide some hope, inspiration, and education for anyone experiencing pancreatic cancer. Sharing the real-life stories of those really affected by this deadly disease and how they deal with it. And today, it's not so much a story. Maybe we're going to clear up some misinformation. What do you think, Roberta?
Well, we're certainly going to get educated. I'm looking forward to learning a lot more. So today our guest is Shelby Yaceczko. I hope I did it right. Shelby is one
just
of...
Just say it real quick. That's good Ukrainian name. Just say it real quick.
If I say it real quick, I'm going to mess it up. That's why I had to break it up. And I'm still not sure I did it correctly. But anyway. So.
We'll have Shelby say it the correct way.
It was great.
How do we say it the correct way?
Yaceczko.
Yaceczko.
Yeah.
Just don't look at all those extra letters.
Close enough.
Shelby is one of only a few advanced practice registered dietitian nutritionists in California. Man, that's a long title.
Big jumble.
Right? Shelby is board certified in sports nutrition and transplant nutrition. Nutrition sport focuses efforts in providing personalized nutritional therapy and treatment of complex diseases, including nutrition for cancer gastro surgeries. And she actually is leading a new program, which I'm really excited to hear about, called Nutrition for Safer Surgeries program with UCLA Aggie Hirschberg Center for Pancreatic Cancer Diseases. Man, that's a mouthful. And I know you have a lot of little letters after your name, but I only recognized one of them. So thank you for being here with us today, Shelby. I really appreciate. I know you had a little bit of a drive, so I do appreciate you coming down. So thank you.
Thank you so much for having me. I'm really looking forward to our talk today and seeing how I can best support to all the listeners out there and open up this dialogue more.
Well, you were at the Hirschberg Symposium, I believe it was in March, I want to say, and you did a fantastic job. In fact, I did receive a lot of emails from people who had attended, had wanting more questions. So I thought, well, it'd be great to have you come on and talk a little bit on Living Hope. So thank you again for doing that. You were studying this Nutrition for Safer Surgery programs. Can you tell us a little bit about what that is exactly?
Yeah, so Prior, I used to be at UCLA Health, and I recently rejoined a couple years ago. And one of the gap areas I felt that we had at the facility was that we weren't quite preparing our patients for surgery in kind of the cancer setting. So I noticed a lot of patients we were operating on who may be undernourished or malnourished, or they didn't quite feel at their best from a health perspective and wellness perspective. So my thought and kind of idea that I put together was, well, how can we help prepare patients who are going through cancer surgeries to be in the best shape as possible so they can lead to a better surgical outcome or have a safer surgery in a sense. So it's kind of this perioperative program of let's get patients ready for surgery. And then after surgery, when they leave the hospital, let's make sure we continue following them so they can recover at home. And thus we can help reduce things like getting readmitted to the hospital later.
Yeah, and can you just kind of go in depth a little bit about your program, what it is exactly? We were talking about the diet before, because I know a lot of times when I've spoken to some Whipple patients, they don't get a lot of advance notice that it's going to happen. Yeah. So is there a certain time frame you need to have, or can you kind of work it in with just a few days, a few weeks?
Yeah, that's a really good question. So we usually know that it's going to take about 2 weeks to really make any kind of difference when we do a preoperative program, or what's known as prehabilitation. But generally speaking, by the time preoperative testing is done for patients undergoing a pancreatic cancer surgery, or just booking the surgery itself and getting ready, it tends to be a couple of weeks usually. So it is a really short turnaround time as is, but it is enough time that we can usually start thinking about things like a wellness program, thinking about things like physical activity incorporation, and then optimizing nutrition, meaning that we may be doing high calorie, high protein diets. We may incorporate a number of different oral nutrition supplements, or really start figuring out if this patient's malnourished or they're not digesting food very well and absorbing, what do we need to do to get them ready so they can be in the best shape as possible for that surgery date.
And if somebody was going to come in and have that surgery and you have the time, what is it exactly you would advise them as far as their diet?
Yeah, it's a good question. So it's individualized. So I really tailor it based on what is the patient currently doing based on things like their cultural preferences, what's their meal pattern, do they eat 2 times a day, do they eat 6 times a day? So somebody who comes to me and says, I only eat 1 meal a day, I'm not feeling good, I'm losing a lot of weight, we're really going to dial in and figure out, well, what's going on at that one mealtime that's causing symptoms potentially, or what's going on in your clinical journey that could be causing some of these symptoms? And then let's really focus in and tailor, do we need to adjust the types of foods you're eating? How much food you're eating? Do we need to even think about things like liquid meals at times to help get you in some energy and calorie to fuel your muscles? And then also, if we're having some digestion issues, I'll also screen for things like pancreatic insufficiency to figure out, is this coming from a place that our pancreas isn't quite digesting and absorbing nutrients as well as it did before a diagnosis?
And is that when you would consider pancreatic enzymes, or does that come in later?
Yeah, good question. So a couple of things I screen for is number one, well, first off, the pancreas has two main functions I like to explain. So number one, it's blood sugar control. So our pancreas secretes a hormone called insulin. So we work through making sure blood sugar control is optimized. And number two, I screen for pancreatic insufficiency, which is essentially where the pancreas may not be producing enough digestive enzymes to really break down and absorb the nutrients, which is why so many patients can lose weight unintentionally or they're not able to gain weight back. So if we notice patients may be at risk or may have pancreatic insufficiency, we'll often start a prescription pancreatic enzyme medication with food to see, does this help improve some of the symptoms patients are experiencing, and are we able to treat potentially the pancreatic insufficiency that's present? What's so difficult with pancreatic insufficiency is there's not really a one best way outside of research to diagnose it, and the tests do have some limitations that we do have with stool testing. So oftentimes we do a trial of the prescription enzymes just to see, is a patient responding to this, and can we improve their nutrition status?
Yeah, I was going to ask, how do they test for that? What is it they look for?
Yeah, so what's most readily available in clinics and in practice is what's called our fecal elastase test, or an FE1 test. And this is essentially a one-time stool sample. And it's really looking at the amount of elastase that the pancreas is producing itself to see if this number is low on the stool test. When we get it back, we may see a patient may have mild, moderate, or severe pancreatic insufficiency. But the test can be, it's reported anywhere around 70 to 80% sensitive. And so there are some limitations, especially if that stool is very watery. It can be diluted. So we always have to think about those things too when we're interpreting a test result.
Yeah, I know a lot of times on the support groups I sit in, the enzymes using them that's something that's always talked about, because I know with myself, my doctor just gave me a prescription, said, here's some enzymes, take them. And it's like, okay, do I take them? How many do I take? Do I take them every time I put food in my mouth? I still hear that. So I was kind of hoping over time it would get better, but I'm still hearing this from a lot of other patients as well.
Yeah, this is one of the things. I think there's a huge lack of education around pancreatic enzyme, just awareness, how to take them, what they're for. Oftentimes we'll see an oncologist or somebody will write a prescription for it, but there may be that kind of barrier in communication or really understanding from a patient or an individual as far as, well, what am I supposed to do with these? Do I take them? When do I take them, and how often? So I can't tell you how many patients have come to me and said, I'm taking enzymes 3 times a day. I take them at 6 a.m., I take them at noon, and then I take it at 6 p.m. And I say, well, when do you eat? And it's not during those times. So we know that those enzymes are really not doing anything, or they may actually be even causing side effects because you're taking them without food. And the point is to have enzymes with food. So that's one of the things I like to do, is a little bit of an enzyme teach session, just to make sure that we're taking enzymes correctly and patients and individuals understand what the purpose of enzymes are. Because we know when we understand as individuals why we're doing something, we're more likely to do it and be successful with it.
Well, it's easier to do if you know why you're supposed to be doing. And
absolutely.
And can you just maybe briefly just explain? So like I said, a lot of times, do you take them when you're snacking, when it's a full meal? How do you know when you're supposed to be taking the enzymes?
Good question. So enzymes are prescribed to be taken with all meals and snacks. However, there are a little bit of consideration. So for example, if somebody's just eating a couple bites of food, so let's say that maybe they're feeling a little nauseated and they want to eat a pack of saltine crackers, something very minimal. I wouldn't recommend taking enzymes with something so small or so tiny in composition. If somebody's going to eat a couple carrot sticks, you wouldn't necessarily need an enzyme there. But something that's containing a little bit of a fat content, or is going to look more like a regular snack or meal. So for example, maybe some yogurt with granola. That would be enough of generally speaking, a snack item that you'd probably want to take an enzyme with. And this may change a little bit depending on the patients. We notice some patients may need to take more enzymes with certain meals with higher fat content or more portion of food. So it's not always just, take 2 enzymes with each meal. It may be that you may need 1 here and 2 here and 3 here and 1 here. So it's really an individualized process, but it's a little bit of an enzyme art, I like to call it, when we work together.
Is it kind of trial by error?
Yeah, and sometimes I tell patients very, upfront, this may take a couple of weeks to a couple of months for us to really understand what your body is going to need from a digestion respect. I generally give around 7 to 14 days when we make a change with any kind of enzyme dosing to better understand, is this working? Are you responding? And how are you feeling? So keeping a GI symptom log can be really helpful along with keeping a food diary. So for example, I'll encourage individuals I work with to write down kind of the foods that they're eating and how much they're eating of those foods, and then to better understand how many enzymes they're taking, when they're taking those enzymes, and what their stool patterns look like. So that helps us really paint a picture and create awareness both for me and the individual I'm working with as far as I was having symptoms with these particular food items, and I noticed these trends as far as my enzymes in my stools and my symptoms. So that's a nice way to just create pattern and awareness to figure out how can we best manage your symptoms and allow you to have peace with your meal times and peace with your digestion.
I know sometimes it's hard too, because I can eat something one day and totally not bother me at all, and I can have the same thing maybe next week, and it's like, oh my God, I never should have eaten this, because I'm not really great always taking my enzymes either. So is there a reason why sometimes your system will take something really well and the next time maybe not?
Yeah, I would also, I look at things in a big picture, meaning that if we're going to eat the same food, how much are we eating consistently? So let's say, for example, avocados, which are a nice, healthy fat source that are considered an anti-inflammatory fat source. So maybe you eat a couple slices of avocado on your eggs in the morning and you feel great. But then you eat avocado toast, and we think about it, avocado toast may have much higher amounts of avocado on there. You may have half an avocado, so much larger portion. So it may be more of a portion related perspective, not the food item, but how much are we eating, as well as what does the rest of the meal look like. So if we're adding things like a lot of oils or other types of fats, which we know fat can be the nutrient that causes the most maldigestion or kind of GI symptoms, if you will. So I also look at the meal in total versus just the food item itself. And then we start thinking about things like portion of those food items too.
So it really is a good idea to keep a log, and we always talk about it. It's not something anybody wants to really look and consider what their stool looks like, but it can be really important, sometimes, right? Yeah,
and that's something I think sometimes patients give me these big wide eyes on our first visit, because we really just dive into the stools. So we have a long conversation is, what are your stools looking like? Are they floating? What color are they? Are they greasy? How many bowel movements? All these fun things. And I get sometimes people like, what are you asking me this for? So I like to keep them empowered. Some patients love it so much they send me photos of their stools every day. It gets, it's whatever works as long as we can help address the symptoms. I think that's kind of my philosophy.
Yeah, that's sometimes when I go in, my nurse says, floaters or sinkers?
Yeah, that's what I like to use the hand motions. Are we going floating? Are we sinking?
I think Paul has a question for you.
Oh my God! I just got to pipe up, because now you've just validated. My late father used to keep a daily log of his poop, and he would take, and he had his own classifications for everything. And he'd take it to the doctor, and the guy's like, "What am I supposed to do with this?" I just thought you'd want to know day by day. Was it dark? Was it floating? Was it doing this? Was it big? Was it small? And he'd check color and all this stuff. Before we run out of time, I want to talk about the thing we were talking about beforehand, sugar. You're talking the pancreas has something to do with regulating sugar. And I have more people come in the studio and start preaching sugar. That's what feeds cancer. Any kind of cancer, sugar is bad. Is that real, or is that...
Yeah, that's a really great question. You go on the internet, and this one you could dive into for weeks, years, and you're going to get 1,000 different opinions on this. But I'll give you kind of the overview of what we know from our organizations like the American Cancer Society and other evidence-based practice groups and organizations. But we know that it's not necessarily that sugar feeds cancer directly. The association is less direct than what's often portrayed on the internet, but it's that sugar, when we're eating too much added sugar, that can lead to things like increased tummy tissue, or increased adipose tissue is what it's called. And we know that increased tummy tissue can create inflammation over time, leading to things like chronic disease development, one of which is cancers. And we know that having, that relationship is more related to the development perhaps over time, or that more indirect association. So one of the things we really focus on is maintaining a healthy body composition where we have strong muscle mass, we have, an appropriate amount of body fat on our body composition, and we're maintaining an overall kind of healthy, balanced lifestyle, incorporating things like physical activity, wellness, meditation, good nutrition practices, sleep hygiene. So all of these things work together to reduce stress levels and reduce inflammation and feed our body with the fuel that it needs, thus reducing things like cancer risk. So not saying that sugar, we should go eat a whole bunch of sugar, but it's not necessarily that eating sugar will cause cancer. We know that if you stop eating sugar, that will not shrink your tumor. And if you eat more sugar, that will not speed up your tumor growth.
Because wasn't that one of the things you did, Roberta? You cut out sugar. You used to drink Dr. Pepper like an addict or something here, you said. But you cut your sugar way down, or cut out a lot
Yeah,
of
I
sugar?
gave up. My doctor said you have to give up the Dr. Pepper, and I'm like, you're crazy. But, I did. And again, I don't know if it was changing the diet, adding like yoga and meditation, all that.
Yeah.
But my tumor became dormant in 2018, and that's when I made some health changes.
Yeah.
So
So probably that combination of making, nutrient dense food patterns. So added sugars, they may play a small role in the diet, but they shouldn't be the focus, meaning that there may be a time and place we may want to enjoy our favorite dessert or added sugar food item, and that's very reasonable. But most of the time we want to be focusing on what's called the American plate, which is what the American Institute of Cancer Research really recommends and promotes, which is 2/3 or more of our diet pattern coming from whole grains, from nuts, seeds, fruits, veggies, really nice nutrient-dense, colorful foods, and then 1/3 or less of our plate coming from animal proteins. And when we do have these animal proteins, we want to focus on our lean proteins like fish, chicken, and turkey.
yeah, the fact that was something I was going to ask you, because I know at the symposium you talked about the new American plate, which was a little different than the pyramid we'd been
Yeah.
looking at for years. So also, I get a lot of questions. You talked about staying hydrated, and you have 12-point checklist that you showed us. But some of the things that came out was staying hydrated and ways to do that, especially when you're having bouts of nausea. I know for me it was like ice chips was my best way.
Yeah.
But I don't know, for others, what, their question was, how can we stay hydrated when, we're not feeling like putting anything in our stomach at all?
Absolutely. And the first place I like to look at is in the morning time. What are opportunities when we first wake up? Because you have to think when you're sleeping overnight, you're in a sense fasting, right? So we're not eating and drinking for the most part overnight. So when you wake up, you're kind of dehydrated already at baseline. So that's one of your prime opportunities and areas to think about. If you don't drink water first thing in the morning, can we plug in a cup of water, a half cup of water first thing to get us going? So that could add, 8 ounces right there. And then I like to break up our day into chunks. So many people I work with, they say, oh my gosh, I haven't had a sip of water since 2 p.m. And I'll have a visit with them. And so I say, okay, well, let's start timers, and we're going to break up our day into 3 chunks. So let's say from morning to noon, from noon to 4 or 5 p.m., and then from 4 or 5 p.m. to bedtime. And ideally, we're not drinking a whole lot of fluids for the hour or two before bedtime, so we can have some good sleep and we're not waking up to use the restroom. But that way we're spacing out our fluids to where our body's able to better absorb it and use it. And we're not over drinking at just 1 or 2 hours of the day trying to make up for all the lost time that we forgot about.
I know when I'm doing my labs, the first thing my nurse says, don't forget your fluids, right?
Yep.
You want to
Yeah.
make sure to try to get it. And it is hard to try to get it in all at one time. So
It's a habit change, definitely.
yeah. Can things count for fluids like coffee, tea, juice?
Yeah,
What-
So all of those things would count for fluids. However, we have to consider with the coffee and some of the caffeinated drinks, how well that's probably really hydrating us. So really the preferred, your body is made up 60 to 70% of water. So we kind of look at how do we get creative with adding extra water into things, whether that's more water into your smoothies, whether that's just carrying a water bottle around, flavoring your water with different maybe fruits, fresh fruits or things, or infusing your water. So I do try to get a little bit creative. You can also do things like popsicles if you're not experiencing cold sensitivity. If you're on treatment and the cold temperatures can be bothersome. So we'll look at even like frozen items to help with hydration. But that may not be for everybody, and we may need to move to room temperature or warm liquids.
Yeah, I actually had a doctor recommend, and I thought it was kind of crazy at first, is to put my water in maybe the microwave or heat it up a little bit, and it did seem to digest a little bit easier and not cause, like, I would get stomach cramps if it was like too cold or which is something I didn't know that was for that. So
yeah, I have a number of patients who anytime they touch a cold beverage or drink a cold beverage, they describe it as lighting me up. I feel like I got zapped. So that's something I always do ask before we start making recommendations. We go through actually what's called nutrition impact symptoms, or NIS is what you'll see them abbreviated as. But this is basically a list of nutrition symptoms that patients may or may not experience during things like chemotherapy infusions. So I like to better understand, what symptoms are you experiencing, so that way we can make sure your interventions align with these symptoms.
And I had some questions. They asked me to go back a little bit because you did talk about diet and nutrition before surgery. What about after surgery?
Yeah, so after surgery is going to be a little bit tailored depending on where you're at from a digestion standpoint. So is the stomach emptying as quickly as it should be? So sometimes delayed gastric emptying can happen where that stomach's not moving as fast. So that would be treated a little bit differently than somebody whose digestion is moving through the tract at a normal speed. But what we'll really start doing is figuring out how do we make sure we're getting enough energy and enough protein to support the recovery after surgery, because we typically have a little bit higher energy needs and protein needs to recover from surgery. And then we start looking at what foods are going to be easy to digest at this point in your clinical journey, and then when can we start liberalizing that, because nobody wants to stay on a restrictive diet, right? Nobody wants to be told I can't eat these foods. Right. So we're really looking as soon as possible to liberalize diet, but also making sure the individual I'm working with feels comfortable with that, they're digesting and absorbing those nutrients, and we're meeting our nutrition and recovery goals. So a lot of it is kind of think of working with athletes, right? I always like to say my patients are athletes. So after they do, let's say you run a marathon, right? You just had your surgery and you ran a marathon. You want to recover from that marathon. You want to prepare your muscles for your next marathon. So that's that kind of recovery phase that we like to focus on.
And I had somebody just ask, you talked about including healthy fats. What are some examples of healthy fats?
Yeah, so some of the more what's kind of thought of as to be anti-inflammatory fats that don't promote inflammation in the body, are going to be things like olives or olive oils, are going to be things like walnuts, certain nut butters. So perhaps a smooth walnut butter, smooth cashew, or a peanut butter, which can often be a nice source of calorie too. Things like avocados or avocado oils. So we really dive into, I think there's a little bit of a myth out there that you can't eat fat if we have anything wrong with our pancreas. But I don't truly believe that. And I think a lot of patients can be really successful with incorporating healthy fat sources. And it's also a great energy source and calorie source. So again, it dives back to looking at the individual person and how much they're able to tolerate and how often.
And after surgery, they would more than likely probably start with a bland diet.
Yeah, so it's there's a whole kind of push toward enhanced recovery after surgery, what's known as ERAS. And some of the best research actually is in pancreatic surgeries, which I love. So it makes me very happy, which means that we can feed patients earlier than we thought. So some patients and some programs are feeding patients on really the day of surgery. They're taking some sips of liquid just to get that tract moving. I like to describe it as if you don't use it, you lose it. So our GI tract is no different. If we're not feeding it, things like atrophy can happen very quickly after surgery. So we want to use that tract to promote normal physiological function and normal kind of release of these hormones and digestive enzymes so we can get back to baseline as quickly as possible. So ideally, starting with some sips of liquids and moving forward to a really GI softer, little bit of an easier to digest diet, in a sense, a little bit of bland, but also making sure we're getting enough things like protein and energy along the way, and we're not just drinking broth, which may not be very nutrient dense.
Yeah, in fact, one of the things that was recommended for me when I was having issues is actually, I was going to ask you, is bone broth.
Sure.
Is that something that is good for you, or is kind of questionable? Or
Yeah, so bone broth can be packed full of good, vitamins and minerals, and oftentimes has a little bit of grams of protein. So it is a great supplement into the diet, but we can't just live off of bone broth.
Right.
So I have some patients come and say, I'm doing Jello and bone broth, I'm feeling good. And I say, okay, well, what's going on with their body weight and their muscles? And they've lost a lot of weight, they've lost a lot of muscle, they're feeling super tired. So we have to make sure we're looking at the whole picture and we're giving our bodies the fuel they need to recover, whether that be from treatment, whether that be from surgery, or whether that be preparing for surgery.
And how often do they meet with you?
Yeah, so generally speaking, I like to meet with everybody prior to their surgery, and then we may actually do a couple follow-ups before surgery if the nutrition goals aren't met, or I find them to be a high nutrition risk for surgery. And then post-surgery, I usually meet with patients after 2 weeks in our surgery clinic, and then I follow them thereafter if they're going to chemotherapy treatment or they're going to be working with the medical oncologist. So it varies, but I'd say typically on average I see patients between 2 and 6 weeks.
That sounds pretty good.
Pretty intensive, yeah.
Yeah, and I wish that was something that would have been an option, even though, like I said, I didn't have surgery. I think a lot of patients who aren't, able to have surgery would benefit from that. So
yeah, and I work with a number of patients who are not surgical candidates as well, and our focus really is on symptom management and improving tolerance to treatment, meaning we keep our muscles strong. We feel ready to go when we do have that infusion therapy that day or that oral medication. So allowing patients to feel empowered during their treatment and that they're at their best wellness that they can be at.
What would be the best way for a patient to get in touch with you if they have questions or want to do this, or is it something that's only doctor recommended?
Yeah, so you can get a referral if you're through UCLA Health, of course, but you can also just look on the UCLA Health page and look up my name, and you can just request an appointment directly from the website without a referral, which is nice. We opened up that opportunity so that way any patients within the community that are looking for additional support, or perhaps they don't have nutrition services available to them, that you don't have to necessarily be a patient with our surgery program to utilize this resource.
Well, good. And I want to thank you again for coming down. The time goes by so fast, and I still have a lot of things, and I have people still popping up with all these questions. Maybe we can have you come back sometime and cover that.
Definitely.
But I do appreciate, again, like I said, you coming down and making the drive and the information. I mean, I'm learning a lot, and I hope everybody gets it. And if they want to learn more, they can go to the Hirschberg website and get this symposium. You did I think 45 minutes on that, and a lot of great information. But I would really love to have you come back and talk some more about this. So
absolutely. Thank you so much. Yeah, thank you so much for having me. And with the Hirschberg, we're working on some new nutrition resources and things in the future. So stay tuned, and we'll have some resources that will be available to the public. So that way we can continue to create awareness around this and make sure that we're giving good nutrition advice and evidence-based advice. Because sometimes when you go on the internet for this, you can really go down a rabbit hole and maybe not get information that's going to promote your best well-being for your care.
We always tell people, please don't Google it. So we want to give them the best resources. Like I said, go to the Hirschberg website.
Absolutely.
And today's dedication, as long as you speak my name, I shall live forever, is dedicated to Juan Jorge. So thank you very much for coming.
Thank you so much for having me.
Thank you.
Well, there you have it. One more reason to tune in each and every time to Living Hope, a weekly journey designed to provide hope, inspiration, and in this case, education for those living with pancreatic cancer, sharing the real-life stories and the real data around this very deadly disease. If you'd like to share your story, please contact us directly here at OC Talk Radio. And if you or anyone you know, of course, needs help immediately, we always give you lots of places to go. Let's give you one that we've touted several times, the Hirschberg Foundation for Pancreatic Cancer Research. Pretty simple, pancreatic.org, P-A-N-C-R-E-A-T-I-C, pancreatic.org. Or give them a call at 310-473-5121. Maybe you can learn more about their nutrition programs here. Thank you all for listening. We hope you'll share this with somebody. We hope you'll come back, because that's how we build this community, by sharing the stories and the information that somehow makes us all stronger. From the University of California, Irvine's Beal Applied Innovation,